Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Carla Lester, pediatrician and life and weight coach. Today's Kevin MD article is an effective treatment using an effective care delivery model using telehealth to treat adolescents with obesity with GLP-1 medications. Carla, welcome back to the show.
Hey, thanks for the platform as always. Happy to be here.
All right, so tell us what this latest article is about.
Well, adolescent obesity is a huge problem in the United States, and it has been now for, decades. And I'm a pediatrician, board certified in obesity medicine and life and weight coach, but I've been working on this issue as I've been on Kevin MD talking about it and numerous issues that come up is working on childhood obesity. And one of the things that I noticed and felt like almost like a failure is in the area of adolescent obesity. It felt like time after time when I was seeing patients, when I was a medical director at a children's hospital of a weight management program, adolescents come in and we're just not being effective and
Mhm.
things would get worse and the rates of severe obesity went up, and especially during the pandemic. And so when I left my position and I got board certified in obesity medicine, became a life and weight coach, started my coaching platform, I was like, the biggest issue facing our teens is not only chronic obesity, but the epidemic of insulin resistance, which is what we're not talking about that enough. And then the Today 2 study came out, which studies type 2 diabetes in adolescents. And really, it's a different disease than in adults. It's more severe. Medications aren't as effective. Teens diagnosed within, 1 to 2 years have early cardiovascular disease. And I'm like, this is the emergency. So I thought, I've got to create a platform, a model. Finally, I'm going to figure it out and be impactful and helpful for teens struggling with obesity and insulin resistance and metabolic syndrome. And so I started a telehealth practice, and then the FDA approved the use of Wegovy for adolescents 12 to 17 as an anti-obesity medication. The American Academy of Pediatrics came out with their clinical practice guidelines. And so I thought, I'm going to just do this. I'm going to figure
Mhm.
out how to use these medications. I'm going to see if telehealth is an effective model to decrease stigma in the treatment of adolescents with obesity. And I wrote this article because I spent some time reflecting and creating a database, looking at my program to see if it indeed is effective. And it is.
So before talking about the platform, just in general, Wegovy and adolescent teen obesity treatment. So tell us about your workflow and when you would consider using Wegovy.
Well, I always follow the FDA guidelines, which were defined by the STEP Teens trial. So, adolescents 12 to 17, BMI of 30 or above, or a BMI of 27 to 30 with a comorbidity. So, that's first of all, they have to meet the FDA criteria. And one of the things that's really important for all of us physicians who do this work, which there aren't very many, is that we need to have more of these kind of platforms and more of us leaning into being willing to prescribe these medications, which are the most effective metabolic health tools I've ever used in my work with adolescents with obesity, because there are so many nefarious bad actors
Mhm.
popping up who are, telehealth companies. They prescribe compounded medications, which are dangerous. If you're an adult, I'm not an adult doctor. That's not my business. I understand the access issues, but for adolescents, we really don't need to go there. But I've learned a lot. We see each other on TikTok, and I've learned a lot of there's just a black market
Yeah.
out there. And parents don't always have their teens' best interest. There are a lot of them are stuck in diet culture. So it's going to be up to us as physicians to adhere to these recommendations and these guidelines. So that's a first thing. And then there's so many access issues that come up. I mean, when I first started prescribing them, it was a wonder to get approval for prior authorization for Wegovy from insurance. And then there was a national shortage of Wegovy. So nobody was getting it. And then there's obviously so many issues with insurance not covering it, them not covering it long term. But anyway, starting with the FDA criteria, most patients have tried different things and they have been, I wouldn't say unsuccessful, but it's because they have probably long-standing insulin resistance or chronic obesity, that it's definitely, they need the medication part of obesity treatment: nutrition, physical activity, behavior, and medication. And there are other medications, but they just haven't been as effective in actually improving weight status and reducing comorbidities.
And you mentioned TikTok, and I do see you on TikTok trying
Yep.
to push back on a lot of the obesity and dietary misinformation that's out there. And sometimes they have no choice but to turn to those, right? Because it's very difficult to get Wegovy. You mentioned in your article over half of prior authorizations are denied by insurance, right? So in those cases where they just cannot get a GLP-1 agonist, what is the next steps for them?
Well, I developed my entire telehealth practice and all of my coaching platform before I had ever heard of these medications at all. So, let alone the FDA approving them. So, there's so much that we can do. I mean, like I said, there's other medications depending on what's going on with the patient, but really getting health data, focusing on metabolic health. I had a patient yesterday who they are not able to cover the deductible to get Wegovy. I fought really hard and worked with insurance. We got approval. We were so excited. But this is a patient who, since she was age 10, had
Mhm.
severe insulin resistance. I mean, she's like a walking poster child for insulin resistance. And she went to a pediatric endocrinologist, and the mom asked about metformin. And this child has PCOS. She's got severe hirsutism, acne, dysmenorrhea. She does have chronic obesity as well. She's got prediabetes. She's got elevated LFTs. She's got the whole thing, metabolic syndrome. And they said, absolutely not. Eat less, move more. And she's an athlete, and she's a good eater. And so there was just so much bias there. But I said, this is what it is: insulin resistance. We went through all the labs. I prescribed her spironolactone. I prescribed her oral contraception, hormonal treatment, and metformin. And she, with changes that she and her mom working together, she's lost 17 pounds. She's had marked improvement in her symptoms and on her exam. And once they can get coverage for the Wegovy, they can afford it and get that deductible down, then we'll start that and add to it. So there's things you can do. There's other medications, nutrition, behavior, physical activity.
So tell us about how your telehealth platform, how does it work?
Well, it's a completely digital platform. I really wasn't thinking that it would be. I thought it'd be more referral based, but every time I'd say, how did you find me? So you can just schedule online at drcarlamd.com, Carla with a K, or on my coaching platform, imecommunity.com, and it has a link to it. So I do get parents who find me on my website. So they Google it. They want to find a doctor who will treat their teen with Wegovy. Many doctors are uncomfortable with it. They're pediatricians, even specialists, or they'll say, absolutely not. That's too drastic. And
Why do you think that is? Why do you think so many pediatricians are hesitant to prescribe Wegovy?
well, one of the issues, and that's a big access issue, is that patients don't have doctors who are willing to write prescriptions. I think there's a lot of time that goes into it. Obviously, prior authorizations, appeals, as we all know, that's a pain. There's a lack of expertise in obesity medicine. Of course, we're afraid we're going to cause an eating disorder or trigger something, and that's what I think a lot of doctors worry about. So my hope is that we can do more education, and that my database that I've created that looks at outcomes and looks at reductions in BMI and improvements in biomarkers that even happen before the weight loss, and improved accessibility, improvements in quality of life, that'll be information that pediatricians can start to really take on the writing of these prescriptions.
So when people find you through your coaching website and sign up for an appointment, tell us about the process that entails.
Okay, thank you. That was your question. Okay, so they find me on TikTok and they'll be like, "Oh, I'm sorry, I found you on TikTok." I'm like, everyone does. And I think it's great for doctors to be on social media, because I showed up to listen and learn when I got on TikTok, but they have a chance to get to know me.
Hmm.
And there's an accessibility there, so they know my philosophy, and they will watch my videos, and so then they can schedule the appointment. It's a consultation that's 50 minutes, and we go through all the information, all their past medical history. And pediatric obesity is so complex. Each patient is completely, nuanced and individual and unique. And so we spend that 50 minutes, and then I always obviously get lab studies, make referrals, work up comorbidities. So I look at causes, comorbidities, and contributing factors. And then they get access to my Health Yourself group coaching course. And the other thing that is a barrier for pediatricians prescribing the medications is because these organizations like the AAP, which I'm a proud member of, and the section on obesity, is that there's so much burden put on community pediatricians. So when they came out with their guidelines, it's like, oh, you need to have a whole intensive healthy lifestyle and behavioral treatment. And I mean, I've developed those with my nonprofit, in the community. It takes tons of grant funding and work, and there's no reimbursement. So it's not feasible for doctors to create all of that. I mean, adult docs don't get that kind of burden on them. And so I think that's one of the reasons why pediatricians are like, well, if I have to do all that at the same time I'm prescribing these, it's impossible. Anyway, I developed a Health Yourself online group coaching course that satisfies that evidence base of contact hours that they need. And so they get access to that. And then I don't have a subscription model, so they follow up when they, I make recommendations. And then once we get the labs back, then I'll determine what medication would be the best for them. And then I'll write a prior authorization if they meet the criteria for Wegovy. And then I have some older teens that do tirzepatide, and we'll see what happens. So, and then I follow up usually like every 4 weeks, 2 months, and then every 3 months on a regular basis. The patients in my database who do well, have improved outcomes, better health, are the ones who have a higher level of parent engagement, which seems intuitive, but it's like the number of visits, the number of communications between us. Those are the patients who do really well.
So, as you know, with the GLP-1 agonist, they have to be prescribed long-term. In the adult population, I prescribe them sometimes lifelong. So certainly, how do you navigate that conversation in the pediatric population?
Yeah, this is such an ethical issue. GLP-1s in adolescents, I mean, I can't think of a more like medical ethics issue. So one of the things is I say, welcome to pediatrics. That's like what we've been asked our whole careers. Well, are you going to start that when he's going to, before we had the Affordable Care Act, is it going to be, oh, they have a pre-existing condition and they'll never get insurance, so they'll never get a job, and so are we going to withhold a diagnosis of asthma or treatment? So I say we cross that bridge when we come to it. I do tell patients, we're learning it's a chronic issue. It's a chronic disease, and a lot of patients will require long-term treatment. On the other hand, I've had other teens who don't need it long term, and they decide, okay, I'm done. And they're, it's not just about weight. During adolescence, you have an increase, like a blip of insulin resistance. And that may be something that helped them get through that. And then they're kind of on track. So it depends on each patient. I have others that, are going to stay on it long term. And I say, we don't know long-term the effects on nutrition, on bone mineralization, on growth, on your, relationship with food. I mean, there's obviously a lot of research and studies that need to be done. And surprising, the FDA kind of went ahead and approved them without having any long-term study, even in adults. But, we'll cross that bridge when we come to it. I decided I'm not going to gatekeep these tools.
As far as you know, is there any other pediatricians that's doing this? Because if they don't have board certified pediatricians online prescribing legitimate Wegovy, as we talked about earlier, they're just going to find compounded medications, other things that probably aren't as legitimate. Is your model scalable? Do you know anyone else that's doing this online?
I don't know of anyone else who has the same model that I have. I think it's not, I mean, just like a lot of things in pediatrics, I mean, I'm not doing this for the money. I say I'm not doing it for the money because if I was, I wouldn't be doing it. But I I think, obviously at children's hospitals where you have weight management programs and they are prescribing the medications and the accessibility may not be there. They may not have a lot of the knowledge are focused on insulin resistance or how to use the medications as much as I believe that I do, just because of what I've learned and leaned into. I think my model is scalable. I'm licensed in 15 states right now, and I hope it will grow and I'll figure it out as it does. And what I would love to have happen is that we have, like, it's a specialty consultant model where they come and see me and I get them started and I get them going and I get all the group coaching and all those supports that need to happen in place, and then they can follow up with their primary care doctor long term, and I can kind of hand them off to them and they can kind of take care of the long term issues that come up and touch base with me as needed. But one of the things that I found in my database, which was really awesome, was that a third of my patients are from rural communities.
Yeah.
And so they don't have these programs available to them, or they have wait lists that are 6 to 12 months, or even to get into a pediatric specialist who'd be willing, if they are, to write a prescription. So it's hard to find somebody. And I have a lot of parents who reach out to me and say, are you licensed in my state? Oh, I wish you were, and not, so I can't. And they say, who do you know in my state who can help me, who's like you? And I'm like, nobody.
We're talking to Carla Lester, a pediatrician and certified life and weight coach. Today's Kevin MD article is using telehealth to treat adolescents with obesity with GLP-1 medications. Carla, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Well, I want us all to be open to novel approaches to treating adolescents with obesity, insulin resistance, and metabolic syndrome, because this is a true emergency and crisis that we're seeing now. And so we have to be able to create models like mine that use telehealth and that are using the most up-to-date, effective tools like the GLP-1 medications, so that we don't have, because the research practice gap is on average 17 years. So are we going to have another 2 generations of adolescents who enter young adulthood without any effective models to help them reach young adulthood without the burden of type 2 diabetes, chronic liver disease, and shortened lifespans?
Carla, as always, thank you so much for sharing your perspective and insight. And thanks again for coming back.